everyone. So my name is Nick, also known as the floating ventilator guy, also known as Nick Pomcrit, usually on Instagram. However, dipping my toe back in to the TikTok pool. And just to give a brief overview on who I am, a pulmonary critical care physician, currently out of Baltimore. I did my fellowship and graduated recently, about 2 years ago. I have expertise in mechanical ventilation and part of the mechanical ventilator course for the NIH, where we teach fellows and attendings throughout the country. So have sort of special expertise in this, which is why I started to do this online and on social media to help everyone sort of benefit from the teaching that we give to the fellows and residents and attendings across the country. So to start out, we teach the ventilator in a very specific way that has to do with the equation of motion that I'll sort of go through. And there's other videos on YouTube, Instagram that might interest some of you guys. So please go check those out. But this is a case that I had and wanted to sort of highlight my approach. So it was a 51-year-old male with, insert your past medical history, although the patient was not on anticoagulation, came in with complaints of GI bleed, had a massive GI bleed leading to cardiac arrest. We achieved ROSC after about 30 minutes of ACLS and reversed the underlying causes and started the blood product resuscitation. Comments that I got that sort of all had an underlying theme. And I guess depending on what position you have in the hospital, you're going to see things sort of differently and have different, you're going to be focusing on. But what I saw commonly was essentially sedating the patient, if needed, paralyzing the patient, increasing the flow, increasing the I time, also decreasing the I time to increase the I to E ratio, which I generally don't pay that much of attention to because I don't think it's that helpful as knowing the specific inspiratory and expiratory times, or increasing the volume. This was a common thread that I saw. So just to get back to where we are at, as some of you may know, sort of this lethal triad in bleeding essentially hinges on three things, which is hypothermia, coagulopathy as you bleed more whole blood, and then metabolic acidosis as your lactic acidosis increases because of decreased tissue perfusion. So if the patient has a cardiac arrest from bleeding, you can pretty well be sure that the underlying cause is acidosis. So it shouldn't surprise anyone what the mechanical ventilator looks like after the patient has ROSC from cardiac arrest. Now, you might not, after we achieve ROSC in the patient who had a cardiac arrest from bleeding. Now, can't really see the mode here, sort of on this cut, but this is PRVC. As you'll come to know, I think PRVC is sort of the worst mode of ventilation for a lot of reasons, namely because as the patient's work of breathing increases, the support from the ventilator decreases as per the algorithm. So there's a couple of things that I want everyone to recognize here. One is that, yes, there is a tremendous amount of dysynchrony, mostly related to the fact that the patient has a very high minute ventilation need. The patient has a high minute ventilation need because of the metabolic acidosis that's underlying. But what you can see is that there's probably auto PEEP, and I've gone over a few different times how to tell if there's auto PEEP, but we can say just from the rate itself, there's probably underlying auto PEEP, even in this patient's lungs that I think were sort of normal, as he had no real past medical history, or at least no COPD or asthma. But because of the rate itself, the patient probably has auto PEEP underlying. Number one. Number two is that the patient's mostly double triggering, right? Someone sort of pointed out that he might have been reverse triggering, but in fact, he's double triggering. There's a little white line here that you can kind of see, and then there's a little white line here that you can kind of make out. So the patient triggers this first breath, certainly, and then triggers a second breath. So a lot of the questions and comments and sort of fixes that I saw were, to increase the total volume. This patient's already getting, and this doesn't sort of show it here because of how sort of desynchronous it is, but if you look through the video again, some of the inhaled and exhaled volumes are 800 ml, right? And they're 800 ml because the patient's double triggering, and we have the set total volume at 400. So if the patient triggers twice, the patient gets 800 ml. So he's already getting a tremendous total volume. He's getting a tremendous total volume because he wants to achieve some minute ventilation need that he has to blow off the incredible acidosis that he has. We eventually did get a gas, and the first gas that we got, the pH was around 6.8 with a CO2 of in the 20s, and then obviously almost undetectable bicarb. The other common theme that I saw is increase the flow. Now remember, in PRVC, the flow is not a fixed variable, so the patient could pull as much flow as he wants. We can, and this is a servo U, so we control the I time, and remember that PRVC is really a pressure mode of ventilation. So while this is a volume targeted with servo, you can still set the I time, and with different ventilators, it's different if you can set the I time or the flow or both. But with the servo in PRVC, you can set the I time. So you could certainly decrease the I time. I don't know how that would help because remember, the patient has a couple different desynchronies, right? He has a cycle desynchrony, he has a flow desynchrony, and he has a trigger desynchrony because it's taken a lot of work to trigger the ventilator, probably because of the underlying auto peep. A lot of people commented that this looks like a neuro sort of pattern of breathing, which I do agree. We're post cardiac arrest, so there could be some neurologic injury that is driving some of this. But remember that we need to figure out first if there's a reason that the patient has this very disordered breathing. If there's no reason and the patient's alkalotic, then we can say that it's neurologically mediated, perhaps. However, as in this situation, there's a tremendous acidosis. So that's the underlying cause of this breathing pattern. His RAS was -5. We provided pain relief. A lot of people commented that we should increase sedation or at worst paralyze. Remember, when you make the decision to paralyze, especially in situations where there's a very large metabolic component of acidosis, we can't achieve the same minute ventilation passively that we can actively. We also can't achieve the same minute ventilation intubated that we can extubated. Unless the patient is very active, like this patient was, most of the expiration on mechanical ventilator is passive. And depending on the mechanics of the lung, especially either with normal lungs or with lungs that have high compliance, such as emphysema, you can't achieve high rates. So if this patient needs a minute ventilation into the 20s to blow off their acidosis from their bleeding, if you make the decision to paralyze the patient, you're going to need to get pretty close to that minute ventilation as you fix the underlying condition, which in this situation was bleeding, which we were fixing. But even if you call the MV need of 20, how fast could you possibly go with normal lungs? At the most, maybe 24 to 26. But remember, if you need to get an MV of close to 20, you're going to be in a pretty high total volume, 600, 700. Because if you made the rate 20, you would need a total volume of 1 liter to achieve an MV of 20, which I don't think anyone would be comfortable dialing in, including myself. Now, because of sort of the chaotic nature of how things went down, we weren't able to put a predicted body weight, although this gentleman was sort of a regular size adult male, so about 80 to 90 kgs. So at any rate, a 400 total volume was probably closer to 6 cc's per kg, which another person had commented that is sort of their protocol in air quotes after cardiac arrest. I have issues with everyone being on 6 cc's per kg because number one, it's sort of not evidence-based in all pathologies, really, except for ARDS. You need to look at the patient as a whole and what their needs are. So in patients with high dead space fraction, such as COPD, you can't get away with a 6 cc total volume because we'll have to breathe too fast because of the dead space fraction that they have. But in this situation, a 6 cc breath is going to cause the patient to breathe and double trigger. And what you're going to end up with is auto peep. My usual go-to in these situations is to switch to something like pressure control, pressure support. The danger with switching to pressure control and pressure support is that you're giving the patient more freedom to do what he or she wants to do with the ventilator, certainly. And this is the result. So the patient pulls a tremendous amount of flow. And because of the I time that I had set it in this point 1 second, the patient gets a huge total volume, right? 1200 ml. What you notice is that the respiratory rate did come down. It came down to 22, which actually not that bad. But in order to satisfy their minute ventilation need, which is even higher, the patient pulls a huge total volume. Obviously, that's not safe either. So what do you do? What can we do to negotiate these two? Because the patient still has a cycle dysynchrony, right? The patient's pushing out against the ventilator before the ventilator is done cycling, indicating that the patient wants to breathe faster. There is probably auto peep because as you can see here, the pressure curve starts to dip down and the patient is trying to pull in to get a breath, which we sort of term delay trigger, which could have a couple of different insinuations, but in this situation, it's probably more like auto peep. and still has a flow dysynchrony because this flow curve is kicked out. So nothing that we're going to be able to do with the ventilator is going to satisfy this patient's underlying neurologically driven breathing pattern that has to do with the acidosis. All we can do is mitigate the danger that the vent presents and try to fix the underlying condition, the underlying problem, and reverse his acidosis. The way that we teach the mechanical ventilator, we essentially focus on three things, which are the goals of ventilation and the goals of oxygenation. The goals of ventilation state that, say goals of ventilation, we should keep the pH somewhere around 7.2, so sort of this permissive hypercapnia, as long as the patient tolerates that number. So there is no magic pH number. We generally less so care about the PCO2, meaning we don't target a PCO2 number. In some situations, such as right heart dysfunction and neuro injury, you need to be careful with the PCO2 and the pH because it can sort of lead to worse outcome. But in sort of the general MICU population, this is what we're targeting. Number two is we want to limit the plateau pressure to certainly less than 30. And then number three is no to minimal auto PEEP. So we want to limit the amount of auto PEEP. We know that auto PEEP is a rate related phenomenon. We know that auto PEEP can lead to barotrauma and possible cardiovascular collapse. However, in this situation, we are fighting with both the patient's underlying pathology and we are trying to ventilate the patient through a tremendous drive to breathe. So during this whole time, the patient was RAS -5, basically comatose. So we gave pain medication sort of empirically because of what happened, but the indication for ongoing sedation wasn't really there. Like I said before, really taking over and paralyzing the patient might be more dangerous in a lot of situations, especially in situations where there's a tremendous metabolic acidosis underneath, because we will not be able to deliver the kind of minute ventilation need the patient needs with a huge metabolic acidosis. This is the underpinning of why we always say we really try to avoid intubating patients with DKA, is because we're not going to be able to keep up with their minute ventilation need. There were a couple other comments about maybe decreasing the I time or decreasing the inspiratory pressure, which I did wind up doing, decreasing the inspiratory pressure to see if I could decrease the tidal volume, which we will decrease the tidal volume because you're with the inspiratory pressure, you're decreasing the delta. And with the inspiratory time, you're obviously decreasing the amount of time the patient spends in inspiration. So the volume will be less. But what happens is the patient just starts to speed up because the patient's trying to satisfy this minute ventilation need. So if you're looking for sort of an answer, I don't know if there is a great one. The best thing you can do is look at the patient, what their underlying pathology is, understand the different modes of ventilation, their limitations and their risks and their benefits, and try to provide safe and effective ventilation for the patient during their acute disease process. This is a particularly interesting subset of, this is a interesting having a patient on mechanical ventilation with bad metabolic acidosis is really challenging. So myself, along with Melody RT, are going to go over this in a YouTube in about a week or so's time. And we'll take a deeper dive into this and different strategies that we both have for ventilating these patients safely with metabolic acidosis underneath and complicating the picture. So if there's any questions, comments, feedback, please leave it in the comments or DM me, always open for discussion.